Hello, my name is Jacob Aticki, and I'm the Director of Education and Advocacy of the University of Miami Public Health Policy Lab. On behalf of the University of Miami Public Health Policy Lab and the AHF Global Public Health Institute, we are honored to welcome you to our Emerging Topics in Global Public Health webinar series, a forum dedicated to knowledge exchange, rigorous discussion, and actionable solutions. It is with gratitude that I extend a warm welcome to our distinguished panelists, Dr. Pedro Khan of Fundación Huésped, Dr. Monica Gandhi of the University of California, San Francisco, Dr. Sten Vermund of the University of South Florida, and Mr. Michael Weinstein of the AIDS Healthcare Foundation. It is now my great pleasure to introduce our moderator for this session, Dr. Maria Luisa Alcaide. Dr. Alcaide is an internationally recognized expert in HIV clinical care and research, driving groundbreaking advancements in HIV prevention, retention and care, and emerging infectious diseases. She serves as Vice Provost for Research and Scholarship, Professor of Medicine, and Director of the Infectious Diseases Research Unit at the University of Miami Miller School of Medicine, where she oversees a high-impact research portfolio shaping the future of HIV treatment and policy. Beyond her scientific leadership, Dr. Alcaide is a dedicated mentor, driving career development initiatives through the Miami Center for AIDS Research and the Miami Clinical and Translational Science Institute. She is deeply committed to building the next generation of HIV researchers with a particular focus on advancing women and underrepresented scientists in the field. Dr. Alcaide, we are deeply grateful for your leadership and for guiding today's conversation. Once again, thank you all for being here. I look forward to an insightful and thought-provoking discussion. Dr. Alcaide, the floor is yours.
Thank you so much, Jacob, for the nice introduction. Thank you to our panelists and to the Department of Public Health Sciences and the Global Public Health Institute for organizing this webinar. This webinar will provide a comprehensive exploration of the future of HIV/AIDS care, examining key advancements in therapies, care models, and public health policies that promote retention and treatment globally. Expert panelists will discuss the development and potential impact of long-term injectable therapies, strategies to ensure access in diverse settings, and the integration of HIV services into primary healthcare systems to enhance care and retention. The discussion will also address clinical challenges as the advancement takes shape, such as combating stigma, closing treatment gaps in understanding populations, and mitigating barriers that hinder progress towards global HIV eradication and the UNAIDS 95-95-95 goals. By delving into research, innovations, and policy developments that are transforming the HIV care landscape, this webinar will offer attendees practical insights into fostering interdisciplinary research and advocacy collaborations to advance the goal of ending HIV epidemic. It is now my pleasure to introduce our first panelist, Dr. Pedro Khan, who will be discussing a current status of antiretrovirals. Dr. Khan is a globally esteemed leader in infectious diseases with a profound impact on HIV/AIDS research and clinical care throughout the world. He's the director of Fundación Huésped, which has led founding in 1989, advancing HIV and AIDS research and advocacy, initially in Argentina and then worldwide. He established Argentina's first infectious diseases unit at Juan Fernandez Hospital and serving as the head of the infectious diseases division and now a senior consultant. He's a full professor of medicine at the University of Buenos Aires and has played key roles in shaping medical education and mentoring healthcare professionals. From 2006 to 2008, Dr. Khan served as president of the International AIDS Society and chaired the conference. He is a trusted expert and has advised WHO, and UNAIDS. He has significantly advanced HIV science and public health policy, and his contributions have earned him numerous honors, including the Citizen of Buenos Aires and the Senator Sarmiento Award. I have the pleasure of have worked with Dr. Khan in several research studies, and it's really a pleasure to have you with us today, Pedro.
Thank you very much, Maria, for your kind introduction. I would like to acknowledge and thank the Department of Public Health Sciences of the UM for this invitation, and it's a pleasure to share this panel with this distinguished speaker. So in a few minutes, I will try to discuss with you the current status of the challenges that we have in terms of antiretroviral therapy. And as you can see, I started with showing a banner of success. Today, achieving viral suppression and CD4 recovery is easy with timely initiated modern, highly active antiretroviral therapy. It's no longer an issue. You have several options, several combinations, but there are still some issues that we need to take in account. Stigma, as has been mentioned, is associated with drug intake in many places. There is also psychological impact linking everyday intake and having an incurable infections. So far, our treatment is very effective, but it's lifelong. And some people have issues with the non-adherence related sometimes to pill size or to issue of swallowing pills. Also, there are situations in real life like travel, weekends, prescriptions refilling, and sometimes in some countries, even this of drug delivery. So the need for long-term, long acting compounds is really important. Why do we need long-acting ART? Basically, because most common of the cause of viral failure is non-adherence. And long-acting regimens bring us freedom from lifelong daily medications, low frequency of dosing, and an optimization of PK and a decrease of inter-individual variability. And this has been shown with some compounds that are already in the market and others that are in the process of being launched. Here I show you a patient survey in which long-acting treatment requiring less frequent doses is one of the priorities for at least more than 40% of the people. And it's interesting to see that in clinical trials in which people have participated with cabotegravir, rilpivirine, and also with lenacapavir, the majority of people being asked if they would like to continue the injectables or switch again back to pills, the majority select to continue with the long-acting. It's true that this is a group of volunteers that entered a study of long-acting drugs, so they were predisposed. But it seems that really it's quite popular among our patients, the idea of not taking a pill a day. You know that when we take a pill, we have the chances of having several steps of drug interactions, pH dependent, drug chelation, first pass metabolism, and transporters on the GI tract. And this can be really avoided with long-acting drugs. And we are not inventing anything. We know that long-acting drugs are already used in human medicine in contraceptives, antipsychotics, and also for osteoporosis. And we have different technologies that can be used, and they are now in the process of being tested. Long-acting injections that we have already, oral nanomedicine, infusion pumps, vaginal rings for prevention, implants like in contraception, microneedle drug pads, etc. The future is based in two-drug therapy. I can tell you this since we did the study of dolutegravir 3TC. All what is coming is two drugs. In some cases, like you see in black, dolutegravir 3TC or dolutegravir rilpivirine or maybe API plus 3TC. What you see in blue are injectables, two-drug combinations, cabotegravir rilpivirine, doravirine islatravir, lenacapavir with vitegravir, lenacapavir with islatravir, lenacapavir with binaps, and so on and so on. But this would not be complete if we don't take into account the social determinants of health. And as you can see in this cartoon, the doctor is telling the patient, I'm sorry, but you have a deadly disease. You are poor. So we need to think about this and think if we are going to try to build an AIDS world based on equality or based on equity. This is an example of equality. Everybody has the same bank to stand and look at the match. But equity would be this situation in which those that are most in need receive more support. I will stop here and thank you for your attention. I'm ready to hear our colleagues.
Thank you so much, Pedro, for your remarks. We will now move to the second panelist, Dr. Monica Gandhi. Dr. Gandhi is an expert in HIV and AIDS clinical care, research and policy, fostering innovation, treatment and mentorship, and public health advocacy. She's a professor of medicine and associate division chief for clinical operations and education in the division of HIV, infectious diseases and global medicine and UCSF. As medical director of Ward 86, the pioneer HIV clinic in San Francisco General Hospital, and director of the UCSF Center for AIDS Research. She's played a transformative role in advancing HIV care and research. Her work focuses on developing a scalable, low-cost strategy for HIV treatment, including novel methods for measuring antiretroviral drugs and gender-specific approaches to PrEP treatment. She is a champion in mentorship, and she founded Mentoring the Mentors, a nationally recognized program training senior researchers, in which I had the pleasure of participating years ago. She has secured NIH funding to support underrepresented early career investigators. And she has received the UCSF Lifetime Achievement in Mentoring Award, as well as many other recognition. Dr. Gandhi will talk about long-acting antiretrovirals for a strategy for those with adherence challenges, the data on long-acting antiretrovirals, and the experience at the Ward 86 HIV clinic. Thank you so much, Monica, for being with us today.
Thank you so much for having me. So I also, just in a few minutes, will discuss some of the data on using long-acting ART, as Dr. Khan just said, to fundamentally get to virologic suppression, because we're in a completely new era of HIV treatment. So I'll just talk about the data on the currently available long-acting combination for HIV in those with or without adherence challenges. What do we do about resistance? And I want to just mention lenacapavir and cabotegravir together as a strategy. Very briefly, we all know that the original clinical trials that studied long-acting ART with a combination of cabotegravir and rilpivirine all were performed in those with virologic suppression and oral ART. These were FLAIR, Atlas, Atlas 2M, SOLAR, and CARES. Pivotal trials, the three top ones led to the registration and the approval of long-acting Cabril, but all were done in virologically suppressed participants. The CARES trial was particularly important because this was actually performed in low and middle income countries, looking at cabotegravir and rilpivirine as a strategy for those who are, again, already virologically suppressed, then switched over half to long-acting Cabril. Half of them stayed on that oral ART, and very high rates of maintenance of virologic suppression in different countries with the long-acting Cabril. Importantly, the 96-week data of this study will be presented at our upcoming HIV meeting in San Francisco next week. However, what matters and what we've all been thinking about is, well, it's wonderful that these work in those who are virologically suppressed, but what about our patients with adherence challenges? And long-acting medications have been helping in different fields with people with adherence challenges, in the field of contraception, in the field of using medications for substance use disorder, or antipsychotics. Long-acting can help with adherence challenges. And we certainly have adherence challenges in our field in the current setting. And certainly these goals are unfortunately even more threatened right now. We are not at HIV control. This was the latest UNAIDS report in 2024 from July. We have still 630,000 deaths a year from HIV, 1.3 million new infections. And of those living with HIV worldwide, the virologic suppression rate is just 72%. We absolutely need to do better to get to our UNAIDS 95 goals by 2030. So what can we do to work on these adherence challenges with ART, there are multiple reasons for it. It can be hard to take medications every day. There are stigma to taking HIV medications every day, and there are multiple challenges like housing insecurity, substance use disorder, mental health. There's many reasons why we need it to be easier to take antiretroviral therapy. So here in the US, there have been 2 studies, big studies at least. There have been a number of smaller studies. that have looked at the use of long-acting ART to help those with adherence challenges. One was in a randomized control design. It was called A5359. Still don't have a publication, but this was shown last year at CROI, which are those with adherence challenges randomized first to getting suppressed on oral ART and then randomized to going to long-acting ART versus staying on oral ART. Importantly, this was not a viremic population. Everyone had to get on virologically suppressed on oral ART, but long-acting ART was superior to oral ART in those with adherence challenges. And we also have been looking at Ward 86 in those who are viremic. So this is an incredibly important population because the question is those who have virologic non-suppression absolutely cannot take oral ART. Does long-acting ART help in achieving virologic suppression? So we, since 2021 at Ward 86, have been using long-acting ART in those with viremia and adherence challenges. And our latest study, which was published in JAMA, will be published in JAMA this coming Friday, really shows that we looked at those who were started out with long-acting Cabril in those with viremia and those with virologic suppression. And the bottom line is the rates of maintaining or achieving virologic suppression were exactly the same in those who started with virologic suppression and those who started with viremia at 48 weeks. This data and data from other smaller cohorts really led to the change in the US guidelines in 2024, both IAS USA and DHHS, to say at this point, consider the use of long-acting ART in those with adherence challenges and viremia because it's impossible to suppress this population otherwise. And I'll just end with the fact that there is a new combination that we want to study for those with adherence challenges. This is actually the population, the combination of lenacapavir. Lenacapavir is a first-in-class capsid inhibitor. It's been studied in highly treatment-experienced patients, of course, in PrEP as well. And the idea that we have, and everyone is looking at, is this idea of putting lenacapavir and cabotegravir together for those with NNRTI resistance, which unfortunately worldwide is still prevalent. Also, rilpivirine is not accessible in low and middle income countries, and it does require a cold chain. So we are going to be looking at studies in the ACTG of this combination of lenacapavir and cabotegravir to try to achieve suppression for those with NNRTI resistance. Thank you.
Thank you so much, Monica, for bringing that really, really key information to manage our patients who may be challenging with alternatives that are easier for them and can improve their health. I have used those strategies successfully, so thank you, because it's always good to go to the data and say, Monica did it. So our next speaker is Dr. Stan Vermont. Dr. Vermont is a pioneer authority in HIV/AIDS research, infectious diseases epidemiology, and public health policy, with a lasting impact on disease prevention and healthcare access. He's the Dean of UCF, University of South Florida Health College of Public Health, Distinguished University Health Professor, and Senior Associate Vice President of USF. He following a transformative tenure as the Dean of the Yale School of Public Health. As a pediatrician and infectious diseases epidemiologist, Dr. Vermont has redefined HIV prevention and treatment strategies, particularly in resource-limited settings. His work on HIV-HPV interactions integrated cervical cancer screening into global HIV care. He has led large-scale clinical trials and implementation science initiatives and serving as principal investigator for PEPFAR-funded HIV programs in Zambia, Nigeria, and Mozambique, as well as major NIH-funded awards. With over 650 peer-reviewed publications, Dr. Vermont research spans HIV, HPV, COVID, and emergency infections, shaping global health policy. He's an elected member of the National Academy of Medicine and a fellow of the American Association for the Advancement of Science and Chief Medical Officer of the Global Virus Network. His mentorship and leadership in global health education continue to drive public health innovations worldwide. Dr. Stent will discuss on fundamental tools for HIV prevention, including behavior, male circumcision, and antiretrovirals, as well as discuss the global response. Thank you so much, Dr. Vermont, for being with us today.
Thank you very much for that exaggerated introduction. We'll spend 6 or 7 minutes on the big topic of HIV prevention, but since Dr. Khan and Dr. Gandhi did such a good job with their enormous topics, I think I can rise to the occasion. So on the left, we have, this is from NIAID and is familiar to many of you. To the left is what we've been talking about, what's in our toolkit for treatment. To the right is what I'll be talking about, prevention. I think the punchline of my whole talk is that at the end of the day, we're going to need a combination of prevention measures if we're truly going to have a handle on reducing HIV incidence beyond that which has already been achieved, because no single measure will do the trick. Use of antiretrovirals for prevention is a compelling agenda. Pre-exposure and post-exposure prophylaxis approach 95% effectiveness with good adherence. But that's the tricky part, good adherence. The largest impact has been in high-income countries, not low-income countries. High access, high awareness populations in places like San Francisco, New York, the UK, Australia, Amsterdam, and elsewhere have had the best success. Topical PrEP, otherwise known as microbicides, has proven unpopular with very low adherence. Long-acting ARVs, as you've just heard, show immense promise not only for treatment, but also for prevention, such as long-acting cabotegravir and lenacapavir. We also use antiretrovirals to treat patients, obviously, and the concept of a high degree of fidelity in treatment, where we can achieve testing for enough people, linkage to care for enough people, and viral suppression for enough people, then those persons become non-infectious to others. So you end up with treatment as a prevention tool. And there's considerable evidence for broad effectiveness, but it depends on the success of the screening and treatment enterprise. If it's marginally covering folks and getting to 50% linkage to care, it hasn't proven effective as a prevention tool. We also believe in sexually transmitted infection control, both ulcerogenic and inflammatory STIs can facilitate HIV transmission, and prevention of mother-to-child transmission was the original treatment of prevention, treating mom to avoid baby from getting infected. Wildly successful, as you all know. Now, minor surgery and blood banks are worth a chat. Voluntary medical male circumcision, which is what that VMMC stands for, reduces susceptibility to HIV acquisition by 50% shortly after the events. And the longer you live in the circumcised state, the greater the aggregate protection is, probably in excess of 70% at the end of the day. And there are substantial secondary benefits to women and infants, because if a man doesn't get infected, then the person's spouse or sexual partner is less likely, won't get infected, much less likely to get infected, and the infant is less likely to get infected. It also reduces STI acquisition and onward transmission. The data are particularly strong for syphilis, but also for HPV and others. Now, VMMC has had a modest global impact. And this is because of uptake being suboptimal. But Western Kenya does suggest the potential. In Western Kenya, the Kikuyu people are ritually circumcised as part of the tradition in adolescence. And the Luo people are very familiar with circumcision. And it's been a relatively easy sell socioculturally. And with very, very high coverage rates, we have seen a prevention effect that most observers believe was at least substantially contributed to by circumcision, although expanded drug treatment has contributed as well. Now, in his address to Congress a couple of days ago, President Trump singled out for termination a grant related to male circumcision in Mozambique, a contract with Asociação Elos, which is a community-based organization. And I was disappointed to hear the president say this because he treated it with considerable contempt, when in point of fact, it is a powerful evidence-based tool for HIV prevention. We now have evidence that men who have sex with men will also benefit from circumcision, fairly dramatic results from our study in China, published in Annals of Internal Medicine last year. Now, we all know about advanced blood banking and transfusion practices, but I wanted to mention it today because safe injection practices are part of this family of needed interventions, and those remain elusive in many low-income and rural parts of the world. Just take a look at the two outbreaks infecting so many people in the Sindh province of Pakistan in the Larkana region. Then we get to individual and community engagement, behavior change, and community programs. Many of you remember the so-called ABC or ABCC, abstinence for adolescents, be faithful for persons who are sexually active, condom promotion, and circumcision promotion, and strategies to get there. This remains compelling and remains a major tool that has enabled countries like Uganda, Thailand, Senegal, and others to have considerable success. Special focus on vulnerable populations makes a lot of sense. Men who have sex with men and trans individuals, sex workers, drug and alcohol users in Southern Africa. You could add teenagers to that list. And help for persons who inject drugs, needle and syringe programs, expanded opioid substitution therapy programs for persons who inject drugs. And then systems changes to improve access. Very dramatically in our lifetimes, we've had PEPFAR, we've had the Global Fund. We're expanding expanding PrEP availability is a priority and has been successful in high-income countries where that has occurred. And we don't want to forget condom distribution, still a powerful tool. Then we have quality of programs where we have failed to virtually eliminate mother-to-child transmission, is where programmatic problems are extant. Persons who inject drug programs, drug stockouts, things that really should not be occurring in a modern medical system, whether in a high or low income country. And then program integration, HIV combined with TB, STIs, primary care, non-communicable diseases, contraception. The more demand you build for HIV services, you will build that demand when people care about other things as well. And we've built such infrastructures around the world for HIV that it's foolish not to deploy those infrastructures for other purposes. There is the HIV prevention pipeline that I don't have time to go into, but this is on the AVAC website down here in the right-hand corner. And it reminds us of all of the different strategies that are continuing to be promulgated, technologies, and our key goal in driving things across to the right into currently available strategies. So I leave you with what I started with, which is the beauty of combination prevention. There's nothing stopping us from utilizing multiple of these tools And we believe that that will be the greatest success. A few articles of interest, if you want to take a quick photo, our website and our College of Public Health and the Global Virus Network. Thank you very much.
Thank you so much, Dr. Vermont. Our next speaker is Mr. Michael Weinstein. Mr. Weinstein is a global leader in HIV/AIDS care, research, and public health advocacy, driving transformative advancement in treatment access and policy. He is the president and co-founder of the AIDS Healthcare Foundation, AHF, which is the largest global AIDS organization. And he has expanded AHF from being a grassroots hospice initiative into a multi-billion-dollar healthcare powerhouse. And this AHF provides cutting-edge medicine and advocacy, regardless of the ability to pay. Under his leadership, AHF now serves over 2.2 million clients across 45 countries, operating over 700 treatment clinics, outpatient healthcare centers, and pharmacies. AHF also supports a clinical research unit to advance HIV science and translating research into real-world care. Michael has redefined global HIV care, launching initiatives in long-acting antiretrovirals, rapid treatment initiation, and large-scale HIV testing expansion. Powerful advocate, he has pushed for policies that expand treatment access, lower drug costs, and influence global HIV/AIDS strategy through direct engagement with WHO, UNAIDS, and global leaders. He will talk about the need to close the treatment gap, importance of treatment prevention, retention, and reimaging outreach. Thank you so much, Mr. Weinstein, for being with us today.
Yeah, I'm very pleased to be here with such an august group of people. So let me start out by saying the history of AIDS Healthcare Foundation, as you mentioned, we started as the AIDS Hospice Foundation 37 years ago. So I think it's important for us to remember, how bad things were, how much better things are. We've come an incredibly long way. HIV was a death sentence in the 80s, and now people are living well with HIV. When it comes to the issue of how do we accomplish HIV control, I think it's time for a reevaluation and to look at this very, very directly. I mean, as Dr. Vermont mentioned, treatment as prevention is the most critical element here to breaking the chain of infection and bringing the number of people who are newly infected below the number of deaths, thereby shrinking the total number of people living with HIV in the world. I think we've moved away from focus on treatment as prevention in terms of a lot of discussion. There's been, and a big focus has been, for the last few years, has been biomedical interventions. But, arguably, the biggest gap in the world in care really has to do with adherence and retention, or even things like washing your hands, in a hospital. When you look on a global basis, we've come a really long way. Most people living with HIV know that they're HIV positive. That's a remarkable accomplishment. And they are routinely referred for care. And a large percentage of them make it to a first visit. But on a worldwide basis, if we don't close the treatment gap, we are not going to succeed in controlling HIV. I have to say also that, I look with skepticism on the numbers reported out of UNAIDS about treatment coverage and even about viral suppression, because in all of these facilities that we enter around the world, in the vast majority of those sites, the count is cumulative and is not based on audits of charts and is not based upon current population attending clinics. I mean, what's one of the most shocking statistics to me is that only half of all people living with HIV in the United States are in routine care, meaning they're seen at least every 6 months. So when we look on a worldwide basis, how do we address retention in a most effective way? And we're going to have to look, first of all, to the community, right, to assist us. We're also going to have to engage patients beyond them showing up at a clinic. How do we get them in for their appointments? This is so critical, right? How do we support them in lifelong treatment? And so far, we have a long way to go in that respect. The other question is the people who don't know they're positive and we need to be tested, and the people who are positive and not in treatment, we're going to have to reimagine how we outreach to them. I mean, at AIDS Healthcare Foundation, we have community health workers, not only across the world, but in the United States. Okay. We have to focus vigorously among our own staff. They make the reminder calls to get the patient in, that they switch patients to telehealth when they are not able to make it in, and that we address the comorbidities and also the social determinants of health. That takes a really, really vigorous effort. And also, we haven't put front and center client satisfaction. In most places, it's not measured. And even when it's measured, there aren't follow-up plans as to how to address the concerns. The attitude of a healthcare worker, whether it's the person greeting them when they first come to the clinic, whether it's the nurse, whether it's the doctor, whether it's the pharmacy, is of critical importance. Poor people are, despite the fact that they have a grave disease, will walk away. I mean, the other issue is that we don't gear our facilities to express service. Talking about people who have to earn a living, and yet they routinely have to go to a government facility where they spend most of the day, right? It's not necessary, because we can have the stable patients come just for the pharmacy or a check-in. They don't need to be seen by the providers. I'll just say also that about the injectables. Okay, so cabotegravir has been on the market now for 4 years in the United States. For HIV, as well as the alternative for PrEP, and the uptake has been slow. And I think when you're talking about lenacapavir on a worldwide basis, it's not going to be the magic bullet. First of all, of course, is the cost, but also if we have long-acting medications on a wide-scale basis, how are we going to stay connected to these patients to make sure that they come back? The other issue is that we're going to have to deal with the cosmetic issue, which is that it's going to leave the nodules, which people are going to have to, in terms of stigma, are going to have to explain to their partners. So I think that it's extremely important to have these long-acting alternatives, but it's not going to be a panacea. I think it's sometimes being portrayed as. And lastly, I'll just say that the separation between the science and the operational research is absolutely critical and has been given short shrift. And last thing, which is very simple, practical thing, is we need an audit, a 100% audit of all the people on treatment around the world, to really get a view of, how many people are in routine care, how many people are on medication. And we can't really measure viral suppression when so many people around the world don't have access to viral load testing. And we shouldn't forget baseline CD4 viral load should not be counterposed to having a baseline CD4 level. It's important in motivating the patients, and it's also important in understanding where we are in the epidemic. So I really thank you for the opportunity to address the audience. Thank you.
Thank you so much, Michael. Those were all great points. So this was really, really great. So we talked a little bit about the status of antiretrovirals, long-acting injectables. Clearly, are the new kids on the block, and really we have to think about how to best utilize them. Monica gave us some alternative approaches on how to use them in ways for which they were not initially tested for, and some promising data. Heard about prevention, always thinking of other interventions that is not just biomedical, but also behavioral, as well as circumcision, which we tend to not think about it as a really, really driver of potential prevention. And then talking about how to incorporate all these components into the real world, into the clinic, into really serving our patients, and how to get our patients in clinic. If anybody has questions, you can put them in the chat, and Jacob will send them to me. But I do have some questions that we've received before, and just gonna send them to the group because I think each of you will have something to say. And I think it's about long acting. I think we are all excited. Our patients like it. We like them. They seem to be really, really acceptable for those who use them, and have the potential to really revolutionize how we treat HIV as well as we prevent. What are the biggest barriers to widespread implementation, not only in the US, but also in resource-limited countries?
You know, one thing I will say, and it's a very tragic time in terms of access, because you know, long-acting ART, studying cabotegravir and rilpivirine in the CARES trial, which was in Uganda and South Africa, there is no availability of rilpivirine for that partnership with cabotegravir in low and middle income countries. Part of the reason that we're pushing in the ACTG so hard on a large study of lenacapavir and cabotegravir in low and middle income countries is due to that lack of accessibility to rilpivirine, as well as actually inherent limitations of rilpivirine, having a low genetic barrier to resistance, having a cold chain requirement, and having the circulating NNRTI resistance from years of efavirenz use. So we'll find out very soon, but it looks like we're going to be approved to do a trial of lenacapavir and cabotegravir in low and middle income countries among those who are failing the standard of care, which is tenofovir, lamivudine, and dolutegravir. So that would be exciting, because we're definitely in a space where these are accessible, at least in terms of treatment, in high-income countries, and not accessible in low and middle-income countries. And that's not where we wanted to be, like we were with oral ART at the beginning.
Thank you, Monica. Anybody else? Maybe Stan?
The long term, I completely appreciate what Michael has said about the challenges of long-term therapy. Their cost is a major inhibition. And we're just hoping that global pressure, global demand, competition, generics can help drive down costs, as it did for antiretrovirals in general in the early 2000s. I do think from a prevention point of view, it's hard to take medicines every day. I have to take medicines every day, and I forget sometimes, and it's just not that easy. And I'm highly motivated because I'm trying to control my blood pressure. And an HIV infected person is presumably highly motivated to kill the virus. But someone who's not infected and not ill, in other words, we're worried about their risk, may be less motivated. And that's been our experience in actual field studies. So having the ability to take a shot every 6 months versus pills every day could be a game changer for both treatment as prevention and for PrEP.
I think the elephant in the room, I really do want to comment is the accessibility even of PrEP, right? So when we think about what's happening worldwide, again, we do have to comment on the current administration's priorities, and the right now that what's happening with PEPFAR, very disturbing, and then USAID. But also just want to comment that the lenacapavir licensing is going to go through voluntary licensing according to the company, and we don't know about accessibility, especially in Latin America, for example, with not having a voluntary licensed partner there. So we have to be very advocates in our world for this.
I think that we need to take in account that beyond the advantages that are undisputable of long-acting treatments, there are some issues regarding implementation. Nowadays, we are seeing our patients every 6 months, at least in Argentina. Those patients that are adherent and are taking their medicines, we see them every 6 months. With the current long-acting drugs that we have in the market, cabotegravir and rilpivirine, you need to see the patient every 2 months, putting a kind of burden on the infectious diseases units or the units that take care of those type of patients. By no means I'm against long-acting. I'm absolutely in favor. But we need to take in account the challenges, particularly in low-income countries, for this type of medicines. If it's every 6 months, like the case of lenacapavir, provided that lenacapavir gets a bride to have a combination that can be applied every 6 months, the situation would be very different. Thank you.
Thank you, Pedro. Michael?
Dr. Gandhi, my question is, why do you think that the penetration of the long-acting in the United States is less than 5%? It's been on the market for 4 years. It is paid for by insurance, although you have to jump through hoops. Why do you believe it's so low?
Actually, we have 450 people in our clinic of 2,600 on long-acting ART. I think it becomes a matter of success begets success. If you get used to it, if you establish clinic-based systems to give long-acting ART, we have an LVN who gives it out very routinely. Don't have to wait in line, just go straight to the treatment room, get the injections. You can actually get comfortable with it. And I think that's what's happened is there's a barrier to implementation from providers. It seems more difficult. And you have to sort of talk to clinics that are doing it and get used to it. I will also say that Medicaid in California covers long-acting cabotegravir and rilpivirine readily. And so we've also been lucky because we serve a low-income population on Medicaid. If you are going through hoops with private insurance companies, sometimes those hoops are too difficult to manage and you just continue with the oral. But if I would encourage people to come to our clinic, hopefully people are coming to Croy, and do come and see our setup because there's simply nothing impossible about it. You just have to get used to the systems and establish a system to give it out.
Thank you so much for
I'll
the.
just say also that the PrEP, if I could, just finish follow-ups, is, I mean, we've been promoting PrEP so very heavily,
Yeah.
and yet on a worldwide basis, there's only 3.5 million people.
Yeah, and
That's going to make a major difference.
And you touched, Michael, in exactly how I was gonna ask the next question, which is, I think we have really amazing tools, but why the uptake has not picked up for some of them. Long acting is one, the other one is PrEP, perhaps in addition circumcision. So I'm gonna ask a different question: is why do you think that these tools that we know work? They haven't really been that impactful in really reducing the numbers and in the uptake for the US as well as international settings.
I think we can say that oral antiretroviral therapy has been wildly successful in reducing mortality worldwide, including some of the world's poorest countries, as well as helping tip incidence rates towards the downhill course rather than the uphill course that they were on for more than 30 years. So we've got wild successes. PrEP has not been a wild success except in selected high access areas. And I think I alluded to why I think that motivation is low when you feel fine and you're not sick. Why do you take a medicine? It hasn't proven to be compelling. So our challenges in community education and engagement are substantial. I acknowledge Monica's point as to access. If you don't have access, it doesn't matter how motivated you are, you can't take the pills. But even where access has been demonstrated, we have a lot of demonstration projects from Africa and Asia that were not successful. We got people on PrEP, but they didn't stay on PrEP. So I think PrEP is actually still a concept in development. I do not think it's been demonstrably effective. And then other areas, circumcision comes to mind, where we know it works, but men don't want to give up their foreskins. That just hasn't been a wild sweeping demand for a surgical solution. We don't have a vaccine, and of course, behavior change. You have to continue with every new generation, every new crop of teenagers who become young adults. You've got to have a continuous sort of culture change to really have a tremendous success. But I want to acknowledge the successes on the treatment side and the reduction of mortality. It's been a miracle in my lifetime.
But I also want to comment what you said, Dr. Vermont, that we have to admit that it's harder to take a pill every day when you don't have an active infection. Preventative care is always been harder than treatment. And so I think we don't yet know what's going to happen with lenacapavir, and I have a lot of hope for it. But because once every 6 months is very easy and it's highly effective, but we need that access.
I'll just say that, if I could, given the political climate situation we're in, I think our singular focus should be to get and keep as many people in the lifeboat of care as we possibly can. And I think we are going to be required to go back to basics. The promotion of PrEP principally by Gilead destroyed the condom culture as we should have known it would. And we just came off of a glorious celebration of International Condom Day in 48 countries, and wildly embraced by the population and the governments. I think that we can make injectables available around the world, but we can't have the tail wagging the dog. Keeping people on oral medications, which they largely in the world, adherence around the world is pretty good, better than in the United States. Keeping people coming to the clinic, that's more of the problem.
It's a difficult time for our HIV goals. And I think I agree with you there. And I think we have always rallied and advocated in the past, and we have to do that now.
Thank you. So I think this is a good time to kind of wrap up and really thank you. You said it, Monica, it is a difficult time for the work that we do, for the work that we do in research, for the work that we do international. But we are researchers, we're resilient, we work for our patients and for our communities, and we will do all we can to make sure that we have the tools, we can prove they are effective, we can prove they are safe, and we can find ways to give them to the communities that need them the most. I really, really thank you. This was really an incredible panel. I thank you for taking your time to be with us today. And I will let now Jacob close the webinar. Thank you again.
Thank you so much, Dr. Alcaide. On behalf of the University of Miami Public Health Policy Lab and the AHF Global Public Health Institute, we extend our deepest gratitude to our esteemed panelists and moderator, for their invaluable insights, and to our audience for engaging in this critical discussion. We are also grateful for the collaboration of our partners at the AHF Global Public Health Institute, whose commitment to advancing science and policy continues to drive meaningful conversations like this one. We encourage you to continue these discussions, foster new collaborations, and champion efforts that turn research into impact. We also invite you to join us for future sessions of the Emerging Topics in Global Public Health webinar series, held on a bi-monthly basis as we continue to explore pressing issues shaping global health. Thank you for joining us today, and see you next time.
Thank you.
Thank you.